Here is an EO Alive LeGrand story.
Dr. Timothy Gleeson, a retired anesthesiologist who worked for Grand Ronde Hospital and Providence St. Mary Medical Center in Walla Walla, recently spoke with Brent about COVID-19. Dr. Gleeson explained COVID-19, discussed his opinions about the outbreak, and talked about potential treatments.
Hey, EO Alive TV, thank you for joining us. And today I have a special guest and friend, Dr. Tim Gleeson. And Tim and I have known each other for several years now. And he's a trusted friend. We spend quite a bit of time together socially. And Tim and I were recently having a conversation about this COVID-19 crisis. And I often will talk to Tim about medical advice type issues personally. And I thought it would be just a cool opportunity to have Tim join us today and talk about this. And Tim, hey, thanks for tuning in. You live here in LeGrand, but you're currently on Lopez Island in the San Juan Islands. Yeah, right? Is that right?
Yes, that's correct. We have a place up on Lopez. It's the origin, really, of my wife's family. They settled here many decades ago, several generations, and so we've always considered Lopez Island, Washington, our second home. So here we are. We're mentioning the COVID virus. We've been pretty much quarantining ourselves for the last month, and we decided a change of environment might be kind of nice. So we decided to quarantine ourselves up here on Lopez for another week or so. So my interest, I'm not an infectious disease expert. I'm not an epidemiologist. I'm a retired anesthesiologist, but I've done several years in the military as a family practice, and then did my specialty training in anesthesia at the University of Utah, came to LeGrand in 1979, practiced 25 years at the hospital here in LeGrand. And then the last part of my career, I was full-time in Walla Walla, and then did some part-time fill-in, the last few years, more in the Seattle area. But anyway, I'm very interested in the COVID and been doing a fair amount of reading and research, and mainly because we were in Spain early in March when this thing started escalating, and our kids said, "You better get home, Mom and Dad. We're worried about you." And we were just having a grand old time, not really paying much attention to world events. And so they got us tickets, and we hightailed it back here in the early part of March, and really have been kind of doing the quarantining and social distancing, and just in case we, develop it, which I actually did develop and became positive early in March, and it was a very mild case of COVID-19, coronavirus. Was fortunate, and my wife, being a presumptive positive, also has been quarantined. So we've been pretty much isolating ourselves and feel good. Anyway, that spurred our interest for sure.
Well, I can imagine so. So I had known that. I didn't know if you were going to tell us that today or not, but tell us a little bit about your experience. Tell us, about how you developed it. Just tell me about your experience walking through that.
Yeah. Like I say, it was early part of March, and we were fine, no health issues. We were just, like I say, having a good old time with friends, traveling around, and got the urgent call from our kids, better get home. You may not be able to later. And I think probably it was in that process of coming home with, we were packed in an airplane and airports, shuttle cars and so forth, and just became very intense, crowded kind of a situation. And I imagine that's where I picked it up. Didn't know that till we got home. We were quarantining ourselves anyway for 2 weeks. CDC recommended that after we got home, since we were coming from Spain. So we did that. And then I developed, the day after we got home, I developed a fever, a cough, flu-like symptoms, muscle aches, malaise, no real shortness of breath or chest pain. But I thought, well, the CDC said you better get tested, and I thought that makes good sense. So went to the hospital, very good care there. They were very protected, and we didn't go inside or anything. I didn't contaminate anybody. The nurse came out, was fully in protective gear, did my test, and came back positive three and a half days later. So, but it was mild. It went away. My fever went away in a day. Didn't develop any shortness of breath. I didn't get on that death spiral that you're so fearful of. And I was in a category due to my age and so forth where I might have been more susceptible to that than a younger person. But anyway, it came out well. And yeah, so, but it's very difficult to get definitive answers because there's new information coming in all the time about this virus. One of them is, well, really, how long does it take after you've had it not to be infectious? Because it's obviously a very highly transmissible virus, really can spread easily. And the CDC, or the public health, said, well, after 7 days from the onset of my symptoms and no fever, and your symptoms have improved, 7 days from the onset, you're free to go into public. I said, oh, wow, okay, but I didn't feel good about that. And I still don't. So we are just giving it a full month of self-quarantine, basically. We've done some, we've gone out to stores and so forth, but very, very safe distancing and that masks and so forth, so gloves. So I don't think we're spreading it. I know we haven't, in fact, but we're still being safe. But it sure brought me a lot of finding out more about this virus to the front of my burner, so to speak, of the range top in our household.
I can imagine so.
Yeah.
So well, thank you for sharing that. And it was kind of, you had told me that it was mild enough that had you been working previously. I mean, talk about a little bit about that your actual experience with the virus.
Right. Well, it's having worked with colds and, probably flu-like illness in the past, it was not that bad. I probably 5 years ago would have take a couple ibuprofen, gone to work. Just wasn't that. It wasn't. Didn't cause me to, to need a bed rest, or my feet. Like I say, my fever broke early. I had a few lingering muscle aches, but nothing that I felt worse going to work before. I shouldn't probably. I mean, you feel kind of obligated to show up when everybody's counting on you. The surgeons, the patients who are having the surgery.
Right.
It just, there's a lot of goes into preparing for a surgery. So you just try your best to show up.
And you related that it felt different a little, in your throat.
Yeah.
I talk a little bit about that because I thought that was kind of interesting.
Yeah. Well, it was it didn't feel like a cold. It felt like just a real irritation, kind of a burning in the very, very far back of my nasal passageway. And so that was different. And I had really weird dreams for about 3 or 4 or 5 days. Not bad dream, just really weird. And I had a loss of my sense of smell and taste left. They're back. I came back quite a while ago, but temporarily they were gone. And that's a shame because my wife's a great cook, and we were confined to home, and she was cooking these great meals. And what am I eating here? I couldn't taste it, but that's come back. Other than that, I feel normal the last few weeks.
Yeah. So did Linda come down with any of the symptoms, or?
Linda developed a regular type cold symptoms. No, not the fever, no deep cough, no shortness. It's mostly upper airway congestion, as in a regular cold. Mm-hmm. And but they couldn't test her. And that, I guess, would be my biggest complaint. Not anything concerning people locally, but the fact that there's so few tests available for quite a while, I think is sad, because we couldn't test her. We presume she's positive, and assume she now has immunity. We both do, against future infections. At least that's the most likely scenario after you've had it, is that you now are immune. Although we would like to get an antigen serology test to confirm that, and they're coming up with those, as well as more testing for the virus directly. But that, I'd say, is the biggest deficit in the what I see in the healthcare over the last month. There's the lack of testing, and it's been unfortunate, and for a lot of reasons. But and I'll tell you one. One is that they can't give you a denominator. They don't know how many people out there have actually been infected, are infected. Some people say it's as much as 4 or 5 times the number of positive tests that they've, and that's depends on. So there's no denominator. So to say, well, we have a death rate of 1 in 100. Well, you don't know. You don't have 100. You don't know how many really have it in a community. So it's very difficult. It would be nice to know. People, for just epidemiology's sake, they could trace better where that person has been, who he's in contact with. It would be, talk about flattening the curve. Without the testing, it's more difficult to do. Yeah.
So it's kind of funny on a personal basis, and you and I have talked about this. So I was in one of the meetings that local media folks were in, one of those phone conferences when they said, yeah, we have our first Union County case. And in my head, I'm thinking, I wonder if that's Tim, I wonder, and then we talked later. So yeah, once this is all over, we'll have to give you a T-shirt. This is, yeah, you're
either that or they'll start stoning me at the county, at the county office.
So it's like, patient 1 in Union County. I don't know. It's funny, but Tim, I appreciate you being transparent and talking about that. And because and as you and I have talked, in your particular case, it affected you, but it wasn't severe. No,
like I say, we feel so fortunate that both of us have carried on, and in many ways, the quarantine's been nice. We've had a good time, and we felt well. So,
good.
But it got me really interested in the virus, and I could give you a little bit of virology 101 if you like.
No, that's kind of was my initial idea of this conversation. So teach me, tell me about what you know.
Well, someday when I get to heaven, I'm going to ask God in the top 3 or 4 questions, why did he create viruses? Or mosquitoes is another one, but viruses really are an oddball. They are incomplete organisms, as most people know, and they're much, much smaller than even a bacteria. I mean, like 1/1000th of a size of a bacteria, so they're hard to see. In fact, you can't see them. They're incomplete in that they need a host cell to reproduce and to do their dirty work, so to speak, or not. But they need a host cell to reproduce. And so they're sitting around kind of as inactive things until they find the host. And so this coronavirus thing, that's a family of viruses. And the first ones were discovered in mid-1960s, identified, caused the common cold. Maybe there are 4 or 5 of them that were identified over the years. And then all of a sudden in 2002, whammo, here comes this a version of a coronavirus called SARS. And not only did it create the cold symptoms, but it could also kill you. And so it really got the attention. And they called it a pandemic, but my goodness, over the SARS, I think only infected, of course, again, you don't know that denominator number for sure, but less than 10,000 people worldwide, and out of that 10,000, maybe 800 died or so. But that brought their attention, so they said, well, this is different, and they've discovered that they call it a coronavirus because under electron microscopy it has these spikes on it. You've seen pictures of it that looks like a crown. So that's the co part of it. The vid, the VI is virus, and the D, COVID, the D is disease, and the 19 represents the year that this current virus, COVID virus, was discovered or identified. Okay, so then about 2012, you get another coronavirus raising its ugly head, and that's called MERS, Middle Eastern Respiratory Syndrome. And they first identified that from Saudi Arabia in around 2012 or 13, and that even had less number of infections, but was more lethal. About 30% of the people they identified died from the same sort of symptoms that people from COVID-19 die. You know, the deep, the pneumonia leading to respiratory failure, and then eventually death. So they have this common death spiral for these particular viruses. This COVID-19, of course, you knew came from Wuhan, China, originated, and it is what's called these are zoonotic viruses. In other words, they can pass from animal to man, and I guess man to animal and animal to animal. So it's in that cycle where humans get there. Probably was passed from a bat, probably from these wet markets that you read about, and it appears and then it became worldwide. The thing that was a little bit different about this COVID-19, it's not maybe quite as lethal as SARS or MERS, but it is very easily transmitted, and infectious. So I think it's more quickly transmitted, transferred to other people, can kill you, but is not quite as severe as, say, MERS in terms of lethal death rates. There appears to be two strains of COVID-19, and I'm talking a little bit from the Chinese literature, but they say that there's a L and an S. The L being a more lethal strain, S being milder. Probably the lesser the severity or virulence of, say, the S strain versus the L. The S strain probably is more easily transmissible, but less lethal. I think that's sort of a correlation. It might explain some of the big numbers you see in some countries like Italy versus Northern European countries where there isn't the death rate. Maybe Italy has the more severe strain. I don't know. They don't report that too clearly. What else? It's a sneak. Coronavirus is different, or the COVID-19 is different than the others. It has it's an RNA virus. In other words, there's DNA, RNA. RNA is kind of a half of a DNA molecule, and these RNA, it's basically an RNA genome, genetics, with a covering around it of lipid and proteins, basically. And so it's not doing anything. It's just sitting there as this kind of, some people call it a virion or virion in this stage, but it's a virus. It's just not active. Okay, so the genes of this virus are a little different than SARS or MERS. It seems to have a sequence of genes on its RNA that is very HIV-like. So I think there's perhaps some reason to think this may confuse our immune system a little bit, and then maybe it explains some of how weird this virus is acting sometimes. So anyway, it's just it has a different sequence of genes, and that differentiates it from the other coronaviruses.
So Tim, the other day you were explaining to me, you had an illustration that you had about talking and about generally how viruses connect.
Yeah.
And I thought that was really interesting. Can you share that?
It is. And I love these metaphors or analogies. So I'll try to do that.
Okay.
And so take it in real general terms. But viruses generally, like I say, they need a host cell. And that's why, and this appears that this coronavirus, the COVID-19 and the others, SARS and MERS, like to attach to certain cells to find and I'll tell you how that works, but to find the cell that's just right for them, kind of like Goldilocks. I want to find the perfect cell where I just fit. And these cells happen to be cells that are, if you look at a cell as a balloon, let's say a cell is a balloon in our bodies, and we're going to talk about certain cells that are in the lungs, endothelial cells of the lung, or in the blood vessels, or in the kidneys, or in the heart, or sometimes in the GI tract. There's cells in there that this virus really likes, particularly the lungs and the upper respiratory. And these cells that it likes have these certain receptor sites. Now, all cells have receptor sites. That's how the body communicates cell to cell. It transmits enzymes and proteins between these receptors, and it kind of coordinates itself that way. It's a part of the communication system, so to speak. So anyway, these cells, like a balloon, and on the outside of this balloon, you picture lifesavers that are stuck on the outside. These are receptor sites. They're not inside the cell. They're on the outside, on the cell wall of the normal cells that are lining your lungs, let's say. And these particular receptors, the ones that the COVID-19 really likes are, turns out, ACE receptors, which are very abundant. We take advantage of them in many ways for pharmaceutic needs like blood pressure control and so forth. But anyway, this COVID-19 really likes this ACE receptor, it appears. Wow. Okay, so it gets on this lifesaver that's stuck on the outside of the cell, and it kind of changes that receptor. It starts to do weird things to it. So the inside of the cell, the nucleus, is looking up at that lifesaver receptor and says, whoa, that's not right. That's looking weird. I'm going to fix that. So, yeah, so kind of to its own self-destruction, ultimately, the nucleus brings that receptor inside the cell to fix it. And lo and behold, that's how the virus sort of gets into the cell, so to speak. As soon as the virus gets inside the cell, man, it goes to work. It takes over the replication mechanism of that cell. So it just starts reproducing this RNA strand over and over and over. It's like if I walk, let's say you had a new 3D copying machine in your office, okay? And I snuck in your office, and I snuck and I stole the passcode, and I started making so many replications of myself. And eventually I burst the seams of your office. And that's what the virus does. It just overloads a cell, destroys a cell. Whoa, lo and behold, I'm free now to go to another neighboring cell and latch onto that receptor site. So that's kind of how this virus works. And it does it really fast. These RNA type viruses versus DNA type viruses really can replicate fast. And things can happen very quickly. Their good news is that this receptor site information is useful for treatment, and I think they're strong. Even though it's not approved officially, I think there's a good suggestion why hydroxychloroquine and those types of drugs would work. They also tend to occupy these receptors, or in the vicinity of the receptors, changing these receptors enough so the virus may not be able to land on it and attach to it. So there's some good reason to think that these drugs are, and they've known hydroxychloroquine, even though it's used mainly for malaria and anti-arthralgia, like rheumatoid and lupus treatment. They've been known to have antiviral effects for years. So this is no surprise that it would be of interest, but I think there's good science as to why these would work. And we don't have any of these controlled, randomized, double-blind studies, but yet more and more less reliable, but genuinely important studies. By less reliable, meaning they're not double-blind, randomized, controlled. But now this doctor, the same doctor in France that reported the use of hydroxychloroquine and the azithromycin combination, has now treated 1,000 patients, and the results are remarkable as far as getting patients off. And these are severely ill, most of them severely ill, so either not getting on the ventilator or getting off the ventilator. So the numbers are just pretty impressive, even though, like I say, the criteria to absolutely say this is approved is not there.
So since this particular medication is used successfully with other viruses, and this virus tends to, it has the same kind of acting. It acts like, then there's some indication that this may be at least slow it down or prevent it some. Or
I think, and I think to me, although I'm not an epidemiologist or infectious disease, but it seems that it just seems by the science of it that the earlier one would start the medicine, the better, rather than wait until the patient becomes severely ill. Now this is an anesthesia talk and not an infectious disease expert or
but if you're in our current climate, if people are social distancing, they're not hanging around with folks that are infected. You and I haven't seen each other in a couple of months now. Full disclosure. We've talked on the phone and done a lot of video chatting, but then people really have no risk. I mean, this isn't something they need to run out and ask their physician for.
No, I hope physicians who are treating patients for COVID-like symptoms and COVID-19 would consider this. I would want my physician to. I would probably try my best to get on it. That's me, with just enough of I think there's enough evidence, but I'd want to be under the guidance of a physician and probably someone who's more familiar with the side effects of the drug than I am. I don't prescribe it, but it has, it has those. Like everything, there's a cost, and most good drugs have a potential downside, as we all know. That's why okay.
So, but you wouldn't be surprised, given the national landscape, if that wouldn't be something that they're finding approval for. Or
I would think that they would. The FDA's kind of mutating itself by creating these fast tracks for not just drugs, but certainly for different off-label use, as they call this, an off-label use for a drug. That happens a lot. We use drug, if medically indicated. So short of, of course, they're working on other things, and I hope they're still working on better testing and serology testing for, antibodies for the disease. They're working on, of course, vaccines. They take a while longer, and they're working on antivirals. Those are medications that kind of like antibiotics, only in the virus world. Typically antivirals are harder to they just don't work as well, just because of the nature of the virus compared to bacteria. It's harder to kill it, basically. Go ahead.
No, it's funny. And Linda, your wife, is a pharmacist. Has been for years and years. So, I mean, every time we're all together, it's always an interesting medical conversation, because you have someone who deals drugs all the time and someone who prescribes them.
It's been a night. She was a teacher at the start of our marriage, and then, she really has a scientific kind of mind and outlook on things, and she's an excellent pharmacist, and it's been a great combination as my marriage partner too, to have that in common, and it's fun to talk. She keeps me up to date.
So talk a little bit about how warming up, how that. I mean, where do you see this going? I mean,
well, they certainly, if it's flu-like, and it is, the season is the fall and winter, where it dominates, and I'm optimistic that as the people separate more when the weather gets better, and perhaps there's other factors. For example, in the midwinter, we know how dry it gets and cold, and I think we're more susceptible. Our mucus, or the entry points where the virus gets in, maybe, or it's more of a setup for getting infected. As things warm, humidity rises, we get outside. I'm hopeful that I think it will. I guessing, well, I don't know that, will subside. The numbers will go way down. Yeah. There are a couple of other interesting things about the virus, which I think, and this, if you're a conspiracy person, I'm not, but just as a side note, and this is something I read, is, and I didn't know, but I guess there's such a thing as a military Olympics. And every 4 years, it's international. Military athletes from various countries that are in the military meet, and they have an Olympics, just, like the one that's been canceled in Japan this year. Only they had one last fall, and guess where it was? In October, they had a military Olympics in Wuhan, China.
Oh.
And the first case, really early cases, were in November of 2019 in Wuhan. So very likely the virus is around. And I'd be interesting to trace those athletes just to see if they carried, find out if they were ill, find out if anybody around them was ill, blah, blah, blah. Be interesting to trace, to see if there was some connection there with the transmission and worldwide spread of the disease early on. Anyway, that's just a side note.
Well, and because of the lack of testing, then, there could be that a lot of people have had it and moved through it and we'll never even know. And that's kind of the case where we're at now too, right? Yeah.
Well, it is. Like I was saying, some estimate 4 times at least the number that are test positive is the actual number that's out there that probably have it or have had it. And they may, as been pretty well published, that you may not have any symptoms and carry it, and so forth. So it's a very sneaky that way. Not everybody and people may just pass it off.
Mm-hmm.
I had a little cold. I didn't have a fever, and I didn't, get short of breath and no chest pain and no deep cough. But I had a little cold. Well, maybe that was it.
Yeah. So do viruses, do they ever just stop being less infectious? I mean, you know what I mean? Is there a chance that...
Interesting question.
Yeah,
it really is. And I shouldn't probably speak on that. I'm not a virologist, but I get the feeling that kind of the more the virus gets around, the more hosts it goes through, the weaker it gets. Now, the viruses that kill you, let's see, there's some strains of the COVID-19 that are more lethal, a strain. It seems to die out quicker than the one that can linger and get transmitted easier. Now, that's me. I might be talking out of school here, but that's kind of the feeling I get. So that plus a vaccine, hopefully a vaccine will take care, you'll be immune to all the strains, if there are multiple strains of COVID-19. It can take a while. There are different ways to formulate a vaccine, and then of course you have to test it. So the vaccine won't be here right away for sure. But
right away, I mean, I think I've heard the most optimistic is like a year out, right?
Yeah. Well, they do have the step up because of the similarities with SARS and the MERS. So there should be I can't say that for sure. Again, I'm talking out of school here a little bit, but that may be of assistance in setting up the studies and the procedures necessary to develop the vaccine.
So Tim, I appreciate this time, and you and I spend a lot of time talking about life and the meaning of it and God, and being a believer is very much a part of the thing we have in common in our relationship, and so on and so forth. Is there any throughout this process, has there been a time where I don't know, God has used this in your life to maybe get your attention or speak into your life in a way that he hasn't? I mean, can you talk a little bit about that?
Well, it's still in process. I think the time has been rich for, if anything, I have to just say, for my wife and myself. It was a little scary when we first entered, and it made us certainly more, it brought that home. And my wife and I are, as they say, in the last quarter of our ball game of life, so to speak. And probably, if we're fortunate, I hope I have a few years. And it makes death real, and it enriched our time together. We've had a really good. I've had a great month or more with just the two of us, and I hope she feels the same. I think she does. But there's that. So it makes you realize the beauty. Prior to that, it makes you realize how vulnerable we are. I mean, Mother Nature is not so nice sometimes, I guess is another way of saying it. It makes you realize how vulnerable. Here we are in probably the most first world country, one of the greatest first world country that you think you're protected. We live very safely in La Grande. It seems like we can avoid floods and earthquakes and tornadoes and hurricanes and, erupting volcanoes and so forth pretty well. And yet, here comes this virus, and many people are suffering and dying, and also their lives are so disrupted economically and socially, and I mean, it just makes you realize that I don't want to worship nature. I want to worship the Creator. I think nature has its issues, and why I can't explain why we have viruses that do this. I can't explain why natural things, disasters, so to speak, occur. That's another question for later in my journey. But I know they happen. I know they exist. I know there's a God who carries us through those times, every bit as suffering as we are. So that's the message, for one of the messages out of this for us, I think.
Well, good. Now you have 3 daughters.
Yeah.
And all 3 of them are married and have kids. I'll bet you've heard quite a bit. You've had quite a bit of communication from them over the last. Has that increased during this time?
It's been wonderful. I mean, I bet you've experienced the same. So here technology, with texting and FaceTime and all these wonderful ways, it's not quite the same as being their touchy-feely stuff, but it is a delight to hear from them and vice versa, and see what the grandkids, and they're all being homeschooled now, the ones that are old enough to go to school, and going through that and seeing how their family life is evolving with these quick changes that have been thrust upon their daily lives. And so they're in that process, and there's actually a closer we've experienced a closer day-to-day connection just through the media, through social media, than before. So haven't seen them firsthand, which is sad, but I would like to do that for sure. Looking forward to that. How about you? How about you and your?
Yeah. So we spent a lot of time. I mean, I have 2 grandkids here locally and haven't seen them for 2 or 3 weeks because of the social distancing and so on and so forth. But yeah, a lot of time FaceTiming, a lot of time on the screen. So, but you're right, it is kind of fun. In fact, I was giving Michaela, my daughter in Portland, they have John is about 8 months old, and I was like, okay, I need John's phone number. I need a direct connection, and because it's like sometimes it's like, okay, I want to text my kids and say, put the grandkids on the screen and no one gets hurt. Yeah. So, Yeah.
Yeah.
Well, Tim, hey, thank you so much for
Oh.
being a part of this, and appreciate your vulnerability, and I think it's just great hope for folks. I mean, they're certainly, we hear about the stories all the time. Everybody watches the death rate because that affects us. I mean, and the likelihood is that when we get toward the end of this, we're going to have people that we know in our community that died of COVID-19. That's just the raw reality of it. And so it does have impact on us, but it's just really good for you to be here and to be smiling and to have gone through it. And, because we don't hear about that.
Yeah.
We don't have stories of people that we know that they went through it and they're okay. And, and that gives us hope, because if all you're looking at is the death rate,
Yeah.
and the negative side of it, then that can be very scary.
Yeah. And most, like the numbers show, I think in that, I do believe the number that 80+% have a mild or hardly any symptoms.
Yeah.
So that's a good number.
Yeah.
Yeah.
All righty. Well, hey, thank you so much. And I will look forward to when we can be able to sit across the table and have a glass of wine together.
All right. Ditto.
Yeah.
Thank you, Brent. Appreciate it.
You bet. And thank you, Eastern Oregon EO Alive TV, for tuning in, and we will catch you next time. All right, man.
Hey.